Hi, my name is Mark with Wilderness Medics, and today we are going to talk about end-tidal CO2, or capnography, waveform capnography to be exact. So here at Wilderness, we have a couple of different types of capnography monitors. First and foremost, we have the one that's built into our cardiac monitors. Now, you're going to need to locate the port where we attach our capnography monitor to. On this particular unit, it is on the same side as the blood pressure cuff. There's a little trap door right here, and we are going to push down to open that up. When we push down to open that up, we are going to find two little ports. Only one of them do we use, and that is going to be the one that is darker in color. We just take and we insert the capnography probe, finger tight, and once we turn on the monitor, and it goes through its warm-up, we're going to see the capnography waveform here at the bottom. And we also know that the patient is apneic. The next type of monitor we have is going to be the standalone monitor. Standalone monitor works the exact same way. We turn it on. And once we turn it on, we are going to insert our capnography probe right here on the side. Now, when do we use capnography? Well, we use capnography on any patient that has had an LMA, an ET tube, or any other form of airway adjunct inserted. We also use capnography for any patient who has a chief complaint or signs and symptoms of a respiratory illness, whether that be smoke inhalation, asthma, emphysema, it doesn't matter. We are going to use capnography on these patients. Why is that? Because capnography, it gives us a real-time look at how the patient is progressing, and it gives us a real-time look at how our treatments are affecting the patient. So when we look at capnography waves, we're going to start with what is normal. Normal is right up here on top. Normal, we have the expiratory, we have the dead space, and then we have the inspiratory. And if you notice, it's going to have a slight upward slope to it, and it is going to be nice and uniform and all roughly about the same height. So what do we find when we have somebody who's hyperventilating? If you notice, we have an increase in respirations, and that baseline comes down and down and down. Why? Because there is a decrease in the EtCO2. But what happens when we hypoventilate? We hypoventilate, we have a decrease in respirations instead of an increase, and as we decrease, we have an increase in the amount of CO2 in our body, and so we are going to move upward past the baseline. When we have a patient with either bronchospasms or asthma problems or smoke inhalation, we are going to see the neat little shark fin. And that shark fin is always going to tell us that there is an increase of CO2 at the baseline and that this patient is not having adequate respirations. We also are going to notice that as we come along, that inspiratory area is going to rise off of the baseline. So when we are treating a patient like this, and we are out in the field, we have approximately 11 minutes of oxygen on a C cylinder. 11 minutes at 15 liters per minute. If we're running at 6 liters per minute, we're going to have roughly 20. That is not a lot of oxygen when we could be hours away from the main road, or we could be hours away from getting a medevac flight. So what we need to do is we need to use capnography so that we can conserve our oxygen, our medication, and use it for its best with the patient. So we can look at these shark fins, and let's say we're giving this patient an SVN of albuterol. As that patient starts to improve, that shark fin's going to go away, and we're going to come back to a normal capnography wave. When we see that happen, we can take and stop that treatment and hold on to our oxygen because we may need it later on. Instead of wasting it, we can keep this in our back pocket as a tool we can use later. Now, there are some other strange little waveforms you're going to see. Emphysema. Emphysema works backward. Why is that reversal and slope happening? It happens because those people, their hypoxic drive is messed up. So what do we have here? We have very low volume in tidal waves during CPR. But when we have those waves, even though they're low volume, that lets us know that our chest compressions are effective. Without effective chest compressions, we won't have a wave at all. We're going to move over to ROSC. When we have a return, a spontaneous return of pulses, see we go from low and boom, we come right back up and now we've actually got that upward slope again and we have a nice uniform wave. While I'm working a code, if I am at the airway, I want to be able to see my monitor at all times. I want to be able to watch that end tidal CO2 and how that waveform progresses throughout the treatment. When we have an apneic patient, nice normal medullary cycle, and then a bunch of nothing. So these apneic patients, sometimes we'll get apneic patients with a trauma type situation. Sometimes we'll get apneic patients with a stroke type situation. There are many, many, many patients that are going to display apneic characteristics. But right there, we're going to be able to watch it happen. Hypoperfusion. When we hypoperfuse the patient, we are going to get a steady decrease in the amount of CO2 in the body. But if we are looking at our patient, we have an intubation tube in, or we have an airway adjunct, or we have an LMA in. Nice normal medullary wave, and then boom, nothing. Why is that? See that right there? That's because we had tube displacement. Anytime I move my patient who has been intubated or who is using an iGel or an LMA, anytime that patient is moved, I am paying attention, really, really focused attention to my end tidal CO2 wave. Why? It's going to tell me right away, has my airway been compromised completely? Now, something that we really don't have to worry about much on fires is this. When you have a patient who is on a ventilator, sometimes a patient that we're bagging that is during the middle of CPR, but usually it is a patient that is on a mechanical ventilator, and we have these nice even waves, and all of a sudden we have these weird short choppy little waves. That is when the patient is starting to overbreathe the mechanical ventilation device. It's very important that we see that coming, because when the patient starts to overbreathe the device, or when the patient's starting to overbreathe the bagging, we know right away that we need to change the way we're oxygenating this patient, because if we don't, that patient is going to hyperventilate all on their own, and they are not going to have adequate respirations. End tidal CO2 is one of the biggest tools in our toolbox that we can use, especially when we are out in remote environments. We have long transportation times, and we are going to have these patients for an extended period of time. It is one more big tool in our toolbox that we need to use on a regular basis. And remember, any patient that has been intubated, any patient that has an LMA or an iGel or a king tube or a combi tube or any placed airway adjunct, any patient with signs and symptoms of respiratory distress or respiratory illness or disease, any of these patients, we need to be placing them on end tidal CO2 capnography, and we need to not only be putting them on there, we need to watch those waveforms throughout the time that we're with that patient, because these pieces of information here are going to give us the best picture as to how our patient is progressing, how they are metabolizing, whether they're alkalotic or acidotic. We are going to be able to tell so many things just by watching the capnography waveforms. So I can't teach you possibly everything in the world about capnography in this short amount of time, but what I want to encourage you to do is to take some time, get online, and watch some good videos on YouTube or other places that talk about capnography. If it's been a little while since you've used it, brush up on it, because it's a great tool. And hey, while we're at it, have a great season. Thank you very much for listening.